Tim Cranton here, Training Director and owner of Paramed CZ. I've got a presentation that I'm going to be sharing with you today on tactical medical training and asking, are we doing it right? Because we haven't been able to get the face-to-face training done that we would normally do, I've taken some time just to look and reflect on what we have been providing and some of my experiences over a number of years, and put something together to share with my instructors as well as with you instructors out there and other training centres. At the end of the day, what we want to do is provide the best possible service to our clients, and also at the end of the day make sure that when our students go out into the big bad wide world, they're providing their patients with the best possible standards of treatment. So I hope you enjoy the presentation today. So as I mentioned earlier, I've got a presentation for you on a tactical combat casualty care training. And again, asking the question, are we doing it right? I put the video together because I want everybody to learn from it. And again, as I stated before, we want to make sure that our students are going out there and providing the best possible treatment for our patients. So I'm going to share my screen with you now, and I'm going to bring up the presentation itself. I will be giving you a contact address at the end of the presentation if you want to send me any emails or make any comments, please do. And again, this is all about us learning and all about us sharing. So again, tactical combat casualty care. Are we doing this training right? A little bit about me: British Army combat medic, state registered as a paramedic in the UK, and I was a UK firefighter for a number of years. But I am currently a remote medical practitioner. I'm working offshore on a North Sea oil rig at this moment in time, as well as doing my tactical medical training. I'm United States Police Officer as Standards Training certified as a SWAT team leader, and I am a NATO Special Operations Medical Instructor as well. My training centre is National Association of Emergency Medical Technicians approved, and we conduct the tactical combat casualty care, tactical emergency casualty care, and the all hazards disaster response courses on behalf of the NAEMT. I'm actually NAEMT affiliate faculty as well. So I will assess new instructors, and I will also assess new training centres that may wish to be authorised by the NAEMT. I'm a student, and I hope you guys are too, because we need to be learning all the time. We need to be learning new skills, new information to keep us up to date with our training and our standards. Obviously, I've got a vested interest in medical training and simulation because I'm the owner of a medical training company, and I want to make sure that I'm providing the best product that I can possibly provide for my clients and for my students. It's a personal view of tactical medical training and education, and the views that I'm going to express are my own, and they're based on my experiences and education in adult learning. Any medical techniques that I describe are for use in extreme circumstances, and the presentation doesn't necessarily advocate their practice. Where possible, you need to make sure as practitioners that you seek permission from your patients before you apply any kind of treatment or any therapies that I might describe in this presentation. So my objectives are to provide civilian and tactical healthcare trainers and providers an understanding of what I see as common bad practice, especially in tactical casualty care training. Although you could argue it doesn't have to be tactical casualty care training. It could be pre-hospital, medical provider type training. I want to demonstrate how training scars are developed, and I want to show an example of those training scars. And I want to explain the common misconceptions of what gets described as stress training. I want to demonstrate the importance of accuracy in terms of scenario-based training and simulation. And I want to encourage my fellow instructors and company directors, training company owners, to improve upon their training skills and education and seek out ways of providing a better product and a better learning experience. And I want to stress the importance of regulation and audit of training providers as well by established educational faculties and institutions. So first of all, we need to understand what we mean by training and what I'm talking about when I say training. And in tactical medical terms, we generally define the training as the acquisition of tactical medical knowledge and skills in order to apply the correct tactic, because remember, this is tactical medicine, and or treatment in a given situation, most certainly where injury has been sustained. So as we can see here, we've got a photograph, and this is a still that's been taken from one of our training scenarios, where we've got a casualty that's obviously injured. So I just want you to take a second and look at the picture and tell me what you see. And remember, first impressions of any scenario really count. We're doing our danger response. We're doing our assessment, our situational awareness assessment, so that we can then decide the right course of action. So what do we see? Well, there's most certainly somebody who's injured in a body position that we describe not normal. They're not sat on the chair looking at you. There's blood on the floor, and there's blood soaked through the clothing as well. So we have somebody who we would arguably say here who's injured and has moved from point A to point B. But we also have to think about what we don't see. And this is really important for the students, especially if we want them to react in a certain way for this scenario. So here we go. This is what we do not see in that initial picture. And this is the active threat that's actually hiding behind the door. And if we look closely, we can also see that that active threat is also injured themselves, whether they've self-harmed or whether that injury has been inflicted by somebody who's maybe trying to arrest them or whatever. They also appear to have a weapon as well. So we have an active threat here that hasn't been dealt with and is most certainly not secure. So what should we do? So in terms of response, then we're expecting a scene and threat assessment. We need to get a response from the casualty, and we'd ideally like to know whether they can come to us. Is the threat still active, and is there a risk to you? Can you suppress or limit that threat and then recover this patient to safety? Of course, we need to apply some form of medical treatment, in this case, a combat tourniquet, and think what situation or what phase of care are we in? Care under fire, direct threat care, and make sure that our response is appropriate to that. So we need to assess, we need to plan, and we need to act. We need to suppress or eliminate that threat. So ideally, if we're going to be going into that space, we need to think about where the threat may be coming from, and we may need to have people that have got weapon systems, etc., with them, so that they can make sure that that's secure before any kind of medical treatment is given to that patient. So this is what we want to happen. Of course, then they can take that casualty to a safe place and then apply medical aid using the MARSH or CABCDE process and move the patient from care under fire, direct threat care, to a tactical field care or indirect threat care phase. They can then safely apply any kind of medical aid. Of course, from that point onwards, they arrange for and evacuate the casualty. And this is what we want to happen in an ideal situation. In this scenario, we've got a choice as instructors. We can tell the student that the scene is safe and that the casualty has just been dragged from an incident scene and put in the position that they've been found. Or we could say nothing, and we could have this threat still hiding behind the threshold. And then we submit the students to the scenario, not knowing there's another threat there. Now, it depends on the experience of those students. There may be some within that group that will say, hang on, before we go anywhere near this patient, there could be something else there. And that's what we want. But what if they don't have enough experience? What if they literally just see what they see and then go straight in to try and deal with a situation, not understanding the tactical situation? Now, what we do, or what we commonly do as instructors, is we push students into unknown situations, and then we expect it to work it out, which is all well and good if they know what to do, but a lot of the time we are good at setting them up for failure. too much too soon. And we're also guilty of debriefing students in a negative manner. In other words, that they didn't do what we thought we wanted them to do. We berate them for it and say, you didn't do this, you didn't do that, why didn't you do this, why didn't you do that? And that's a very negative way to provide feedback and debrief students. And of course, what we're doing is we're actively encouraging the wrong thing at the wrong time. Reason being is because we've not completed any kind of assessment. We've not really designed or developed our training scenario, and we've not implemented it, practiced it, and then evaluated it to see if it's valid in a scenario that we could use. A lot of the time, not just organizations like our own, but I oversee other training as well as our own, and I've seen that other people are guilty of the same thing. They will arguably make up a scenario, stick a student in that scenario, and then set them up for failure. So what do we not do? Well, as I said, we don't ensure that our students understand good tactics before good medicine. And remember, a lot of students will come to these tactical medical courses with very little tactical experience. Do you do tactical training with your students or ensure that they understand tactics or dynamic threat assessment before we put them through medical scenarios? Now, we've learned from arguably this mistake, and we make sure that we do that. We make sure that students have got at least a basic understanding of what threats might exist and why they should be cautious to make sure that they don't become casualties themselves or create more casualties. Now, a good way of finding out what students can or can't do is pre-screen them. Now, we most certainly pre-screen our students because we want to know what we want them to know. And if they don't, there's something that we need to do about it, or it just might be that the course that they want to come on is not the right course for them. We do prevent information overload. We don't overly stress our students. Most certainly, again, in my experience, we've literally had students just take their gear off, throw it on the floor and say, I cannot do this. Now, is that the fault of the student, or is that the fault of us, or should I say responsibility of us, for not developing that student more? Ideally, we want to make sure students are prepared for training, and pre-course study in terms of the knowledge is really, really important. Easier said than done, when a lot of training materials that are out there only usually come in English, possibly Spanish, obviously if you're doing an NA-EMT course. But here in the Czech Republic, Poland, Germany, they don't always come in the local language, which can make pre-course training difficult for some. Now, if you can spend the time in creating your own documents, then that's going to make a big difference and provide that information to those students so that they can come, most certainly in terms of the knowledge, more prepared when they come to your course. You need to understand your limitations. I mean, I need to understand my limitations in terms of my prior experience, my training, what facilities I have and what equipment I have and what it is I want to actually achieve. And it's really, really important that we explore why mistakes were made and we correct them. Now, like I said at the beginning, we want to make sure that students go out there and provide the best possible level of care to their patients. And they're not going to do that unless we look at any mistakes that they make and we correct them so that they don't get it wrong when they have to do it for real. There are common training mistakes that we make. And most certainly the ones that I've noticed are that trainers don't know their students as well as they can or could. They don't know who they are, or they don't know what they know. And understanding that this alone can make or break your training. No understanding of tactical movement, poor or no fieldcraft when it comes to weapon handling. People come on tactical courses because, unfortunately, a lot of the time they think it's cool. And yes, they want to be there to learn, but they don't necessarily understand what they need to know prior to coming on the course or what they need to learn during that course. There's a lot of pressure on us to provide a lot of information and our expectations are high when providing training in a very short space of time. We need to train as we fight. And that means then we fight as we train. So we need to try and bring together all of the knowledge, all of the practical side of things to make it as real as possible. But that also means that instructors need to lead by example. At the end of the day, those students are going to go out there and they're going to copy you. Now, they say that's the highest form of flattery. But if you're showing or demonstrating bad habits or not delivering things to the appropriate standard, then they are going to go and do the same thing. It's really important that you encourage students to do what you do. Therefore, you should be leading by example. A lot of trainers out there, unfortunately, and I have met them, their egos are just way too big. Sorry guys, but not everybody is right for the job. We've got people that are super keen. That's fine. We don't have a problem with that. But you've also got those people that literally want to bring people onto a course and they just want to beast them. And is beasting somebody the answer? Now, you could go and do CrossFit training if that's what you really need. And yes, we do need a level of training, physical training and physical fitness when we have students come on the course. But we don't necessarily need to be beasting them into the ground in order to be able to teach them good tactical medicine. There's an idiom that gets thrown about, those who can do and those who can't teach. It kind of refers to those people that are lazy. In other words, if they can't do it, well, it's just easier to teach it. Anybody can read off of a PowerPoint presentation. What it should be is those that have done and choose to teach others. In other words, if you want to teach someone, you have to have a passion for it. You have to want to pass on everything that kind of you've learned through your experience, and they can be good and bad experience as well, and sharing them with other people so that they don't go through maybe the same processes or experience the same mistakes that you did. Like I said, it's all about your patience at the end of the day. There's a lot of students will come to courses and they've learned a lot from YouTube. Certainly the tactical versus tactical, and there's so much stuff out there when it comes to conflicting information. It's like dropping the knee because they've seen on a YouTube video that that's what can be used as an aid to bleeding control without understanding good anatomy and physiology, and understanding that with certain types of injuries and injury patterns, you can actually make injury a lot worse. And that's not a good thing for our patient, especially when we want to be saving their life, most certainly not taking it. Mannequins. There is some amazing equipment out there, and I've had the opportunity to work with some of that equipment and still do now. It's great when it works. And you need to make sure that you look after, you maintain, and you do a course on how to operate this equipment. Unfortunately, again, I've seen some amazing equipment, but it's literally just being used as a static mannequin without all of the other interactions, which is just a complete waste, but we'll talk about that a bit. Correcting mistakes. We're really good at letting students carry on through scenarios and then waiting to the end before we debrief them and tell them all the mistakes they made, rather than saying, okay, guys, stop. Let's take a time out. Let's just look at what you've just done. Tell me why you've done what you've done. Ask yourself, is this going to work? And if it's not going to work, what can we do to make it better? Correct that mistake then, give them the opportunity to do it right, and then come back into the scenario and carry on. Now, that'll depend on where you are. Are we still learning or are we testing? If we're testing, it's going to be a little bit different. What we need to do is concentrate on getting the basics right first. Most certainly when it comes to things like bandaging. People look at bandaging and think, oh my goodness, that's really boring. Why do we need to do bandaging? It's easy, anybody can do that. Now, most certainly when I joined the military and when I first started to learn to be a combat medic, we spent hours on it. but we spent hours on it for a reason, to make sure that when we were under duress and when we were being stressed and we had someone with significant injury, then we stopped bleeding and we knew how to do it properly with good, effective pressure bandages. So here we go. What are we looking at here? We're looking at, again, one of our scenarios where we've got combat casualty care being provided to a patient. And what do we see with this bandage? Is this what we would expect to see? Now, this is kind of later on through a scenario. So really, we could have done something about this. Now, remember, is this training? Is this a learning phase? Or are we waiting for mistakes and then just let them happen and then debrief at the end? Or are we going to stop the scenario and say, hey guys, let's look at this. Do you think this is effective? If it's not, then we need to make it better. Now, arguably, that could be no different than another senior team member go, hey, that's not a good bandage, or the medic comes along to one of his combat lifesavers or emergency care providers, responders, and say, hey guys, this is the plan. This is what I want to happen. Let's make a better job of that bandage. Let's cover all of the sides of it and let's use that pressure bar effectively. Why did it happen? Most likely because we didn't demonstrate how to properly apply a trauma dressing in the first place. Is it important? Of course it is, because we want effective bleeding control, and we're not going to get it if we've got a loose bandage on somebody's arm or leg or anywhere. So let's understand then how we learn. It's really important to understand adult education because we're dealing with adults an awful lot of the time. And when we're learning any new skill, there are 4 levels of integration during its acquisition. And there's some great publications out there. A recommended read for you here is Grinder by Murray in 2006, and it's a book called Training at the Speed of Life. It's a great book that breaks down medical tactical training and how we should and shouldn't be doing it, and understanding, how people learn and how it works. So we've got these 4 levels of integration, as I said, and we've got unconscious incompetence. So you do not know what you do not know. We've then got conscious incompetence. So you know what you don't know and you recognize what you don't know, but you can't do it. Conscious competence is you can do it, but you need to think hard about it. So we've got that skill on board, we've got the knowledge on board, but we haven't had the opportunity to practice it very much. Once we've gained unconscious competence, we can do it on autopilot. We recognize the problem, we know which piece of kit that we need to use, we recover that from our aid bag because we know exactly where it is in the aid bag, and we apply that invasive technique or that piece of equipment as it needs to be done in a short space of time. That means it's effective once you've done it. As trainers, it's our responsibility to make sure we give students information and tell them what they need to know so that they can prepare for the scenarios that we're going to be putting them into. So first stop would be finding out what they know on the first day. So testing them is a really good way of finding out. It's also a good way of putting a little bit of stress on them right at the beginning. We're not pushing them into, a full-blown medical scenario, but we're making them think. And this is what we want to do. You've probably heard of the term MacGyver medic. We want people to think. We want people to do their situational awareness assessment, understand what they need to do, and then carry on, but do it safely. And our job as trainers is to fill those knowledge gaps and then give the appropriate training. And we can do that after we've done a needs assessment, which is arguably what you're doing when you do that test on the first day. Of course, your training needs to be flexible. I've been very used to following, very strict timelines, teach this, teach that, teach that, teach that, and then move on to something else. That's okay if you've got a group of students that can manage that, but most likely you'll find varying levels of knowledge amongst your group of students, and you need a degree of flexibility to make sure that everybody understands what you're trying to put across so that they make the right decisions when it comes to their scenario-based training. You need to identify the needs of the student and provide them. Remember, those students are paying your company, paying your wages, and they're expecting you to provide them with a service, to provide them with you know, something that's of the monetary value that they're giving you. We need to build upon. We don't need to destroy confidence. It is really easy, like I said, to berate and push somebody into the ground until they literally break. But what is that achieved? Arguably nothing, especially if your training periods are within a very short space. Before you move your students on to reality-based scenarios, get them to master those skills. So we have that kind of term that we use. We have crawl, we have walk, and then we have run. And there are phases of training. So we've got students getting to grips with the skills that they need to learn on a basic level, being able to practice them, taking the time to practice them, and then increasing the level of stress or the level of reality before we put them into full-blown reality-based scenarios. Be realistic, guys. Tactical medics are not created in 2 days. It takes time. And I've seen some great medics out there who really do take a little bit more time than others to pick up some of this technical knowledge, especially like me when it comes to things like drug calculations and stuff. Now, obviously, I've got my cheat sheets and stuff, but you don't know that then, and we're expected to know a lot of this stuff in memory recall, and that can be really difficult. So some people need a little bit of extra time. Guys, we need to be discouraging bad habits, especially those students that come on first day of the course. We're doing combat application tourniquet drills and they drop the knee. We don't want to be seeing that, especially if they don't understand anatomy and physiology and what further damage that they can be doing. For example, and remember I said about leading by example, we've got a picture here of combat application tourniquets just hanging off of equipment. Now, if you're going to run your students through a forested area, especially if you're doing combat casualty care training, equipment like this can get damaged, it can get torn. Remember, this stuff is being exposed to the elements. We train in all weathers. Things can get muddy, they can get wet. Medical bags get laid down. A bag could get unzipped and open, and then a student's like, I cannot find my tourniquets. What on earth did I do with them? And in actuality, they're on the flip side of a bag, but they think they've lost them. So we want to make sure that students understand exactly where everything is, but everything they're going to need is going to work. It's going to work first time. It's never going to fail. And it does its job. And if you don't look after that medical equipment and stow it effectively, then it's just not going to work when you want it to. So I'm one of the advocates where I just do not like things hanging off of body armor. I don't like things hanging off of kit bags because that's how things get lost. That's how things get broken. I know because it's happened in real life and I've experienced it. Here we go, classroom-based sessions. What's good and what's bad here? Now, this is surgical airway training. Now, if we've got paramedics, technicians, army medics, whatever, and they're on a 16, 20-week course, having them doing their kind of crawl phase and their fine motor skills by doing it on a table, it's nice and controlled, it's nice and safe. We've got plenty of time to be able to talk students through things. This would be ideal, this would be perfect. But if we're doing a 3-day TCCC course, is this where you're going to be working? Are you going to be working on a piece of flesh or tissue at table height? No, you've got no reference here to a patient's body, their head, their equipment, or the environment that could be around them, in which case you could argue that this is false. Where should we train? Well, I've kind of come up with this term, the 3 T's. My office, most of the time, is the first T, and that's terra firma. And that's on the ground and in the dirt. So most certainly when it comes to combat casualty care, this is where I'm going to be doing my IVs. This is where I'm going to be doing those invasive techniques. And I need to be very aware of the environment that I'm working on and I'm working in. The next level is trolley. Well, this is really appropriate when it comes to tactical evacuation care. So you could create this in a classroom in type environment, but you need to make sure that the student understands what, when, and why. This is when you would do it at this level. Of course, if you can get your casualty to the table in your role 1 or your role 2 clinics or hospitals, then this is where you're going to be carrying out those other life-saving techniques, possibly insertion of chest drains, etc. So think about what level you train at. Where should we train? Use the 3 T's. I found it to be a really useful tool. Guys, please, please, please keep it real. We really do not need to be beating people around the head with bedrolls, harassing them, haranguing them when we want them to perform emergency procedures like a cricothyrotomy. Remember, cricothyrotomies are not done on severed heads. You've got other problems there. And they're most certainly not being done whilst you're being attacked. If you're being attacked while you're providing medical treatment, then you're in a direct threat care phase and you have other priorities. And those priorities are not your patient. They are dealing with that threat. In this case, we could be asking for an accident to happen, especially where we've got a student, arguably with little or no knowledge, working with a very sharp implement. Also understand what mindset we're developing when we're doing this training. I work with the US military, the Office of the Command Surgeon in Europe, and I'm the course director for the International Combat Lifesaver course. So I'm actually overlooking training as a course director, and I'm making sure that training is happening. It's happening in a certain time, in a certain place, and to the appropriate standard. But what I expect of my instructors is that they will lead by example. And not only should my students be wearing body armor, helmet, and carrying weapons, which they would be if they were doing it in a real life scenario, I expect my instructors to do the same. Remember, I said lead by example. So if the instructors are wearing their body armor, if the instructors are wearing their PPE as if they were going to work, then the students should be doing exactly the same. This is tactical medical training. Do we leave weapons unattended in any kind of tactical scenario? Of course we don't. Again, that's an accident and a major incident waiting to happen. It's also not good fieldcraft. This is not good skills when it comes to actually being mindful of threats. Think about what we're teaching. Arguably, we should not be letting things like this happen. I've got a nice rifle garden here. This has been during some training we've done with the military. Needless to say, I've had to make an intervention and speak to the instructors because this is not something that's necessarily the student's fault, although they have a responsibility for it. This should not be happening if the instructors and the trainers are doing their job as well, making sure that people understand that you need to be able to get back into the fight as quickly as possible. And that means having your weapon systems with you. I've got a video that I'm going to show you, and this demonstrates the use of one of the most amazing pieces of equipment that I've come across so far during tactical casualty training, and that's the multiple amputee trauma training mannequin. This particular one is worth around $200,000 US, not including its care package. It comes with Bluetooth, Wi-Fi, it has animatronic movement, and it has a remote operating capability. So what we shouldn't be seeing is any kind of instructor feedback. It's just not needed. Students should not need to ask whether a patient is breathing or whether they're talking or they're responding in any kind of way. Now, if these mannequins have been used correctly or the batteries are fully charged, you will be able to utilize them as best as you possibly can. But if you haven't added batteries and you're not using a controller, you are using a static mannequin that you can arguably buy for about $1,000. So I'm going to show this video to you now. Just give me a few seconds to bring that up. The wonders of technology. So here we go. Have a look closely. So this is a great piece of kit, but notice we've got an instructor there who's grading. Okay, that's fair comment if he's testing out 2 students. But then we've got another instructor who has not got the controller box with him. In fact, all he has is a bottle of fake blood that he can squirt on the mannequin if need be. So you've got a medic here who's trying to elicit a response from this patient, but the patient is not responding. Now, this patient could be responding if a person with a controller had the headset on and was talking through the mannequin via the Wi-Fi, the Bluetooth connection. And also what we see here as well is other people other than the person that's doing the grading and possibly a controller. These other people have no part of this scenario whatsoever. They do not need to be there, and arguably they're a distraction. I think at one point there's a guy spitting into a bottle because he's chewing tobacco. Me personally, I hate that, and I do not want to see that happening anywhere near any of the scenarios that we might be running. There's also people kind of taking pictures as well. And again, it looks great, guys, on social media, but this can be really distracting for students and can get in the way of the scenarios that you're trying to provide. Your grader, your assessor, your other instructor are way, way too close to this patient and to these students. They just don't need to be there. With these mannequins, then they can be 50, 60 yards away. They have great range. The main thing for the tester here is so that he can see that the students are doing the right thing. However, you can actually look and see on your controller module what interactions your students are making as well. Both of those students are looking to the instructor for biofeedback. We don't need to be doing this. So this is a great example of what we would call training scars. Students are used to using training equipment that is not being utilized, and they're not touching real people. You could have a scenario here where you've got an instructor who's acting as the casualty, in which case they'd have a respiration rate, they'd have a pulse rate, and you wouldn't have to spend $200,000 US. I'll stop that for now. So this is why biofeedback is really important, especially if we want our students to handle real patients. Remember, you need to be looking at your AVPU. You want to know and understand whether a patient's airway is patent. You want to know if somebody's breathing, if their chest is rising and falling. And you're going to want to do an assessment of circulation. So you need to know how to physically find and locate pulses. Remember, I said no instructor is required when you're using high fidelity equipment. You just need to know how to use this high fidelity equipment and use it as it's designed to be used. I've got a different mannequin here with a different type of controller. This one that I'm using in the back of an armored vehicle, out of sight of students. I've got the patient, and I am the patient, and I am creating that patient's response based on the computer program that goes with the mannequin. Great piece of kit. And if the student is not carrying out the right intervention, that mannequin will do exactly what a real person will do, and they will die. No instructor required. No instructor required Mark II, a lot cheaper, as I said, than 200,000 US dollars. If you've got trained actors that can provide real life feedback, fantastic. Now, I want my students to see that the patient's airway is open. I want them to see what a chest rising and falling looks like. I want them to touch a real person and find and locate peripheral pulses and central pulses as well. Now, obviously, they're going to be pulses of a healthy person. But if you get your student to give you the right feedback, if that's what you're going to do, so let's say they tell you that the patient's pulse rate is 80, you can then interpret for the scenario that it is in fact 120. So you, as the instructor, can then gear or move the scenario or adjust things as you need to. But what you have got is an accurate bio response from that patient, which is what you expected. Now, you could be feeling that patient's response, their pulse rate on the opposite wrist, but we want to make sure that students know that and understand that and can do it well. Because remember, pulse oximeters do not always work. Wound prosthetics can be used. The good thing about using instructors or actors as casualties is that you can change wound patterns. With a lot of mannequins, they tend to have fixed wound patterns. So students can get very used to dealing with the same wound pattern every time. So try and make sure that you mix up those wound patterns. Use wound prosthetics. You can use wound prosthetics on mannequins, remember. So a perfect example, as I said, of training scars is students asking what's wrong. They shouldn't need to, of the instructor or the trainer or the assessor. They should be asking that question of their patient. We want to make sure that they're touching patients and they know and understand where the correct landmarks are, especially when it comes to doing things like chest needle decompression. You can do something simple like getting them to mark on each other, students, where they would put the NCD needle and do it with a marker pen before they would actually do it on a mannequin. Remember, a lot of these mannequins don't feel like human skin and human landmarks. They are kind of basic representations. So we tend to use mannequins over live casualties, but most certainly I'm going to encourage you, if you've got good actors, if you've got good instructors, try and use live casualties over mannequins. There's a time and a place depending on what you want to do. Why do we habitually do this? A lot of the time we're lazy, and it's about turnaround, especially if we're moving from scenario to scenario. We want to be able to reset quickly, and we can do that with mannequins more so than we can with live casualties. It does take time. Cost and operation of high fidelity mannequins, it's a lot of money, but if you're going to make that level of investment, then make sure you charge the batteries and you know and understand how to use that training equipment effectively. Manage your reset times. Don't do things because they're easy. Do it because it's effective and it provides the appropriate feedback for the student so that they don't develop those training scars. Instructors need training. Again, I will come across instructors who've been provided to me, especially from the US military, and they're combat medics, but they've never really been through an instructor training program. So they don't understand things like development of training scars. They don't understand why, they shouldn't be telling the student that the patient is breathing or they've got a pulse. They're doing it probably because that's what happened to them. Stress. Okay, I'm going to show you another example of stress. And there's stress, and then there's stress. So remember I said earlier on about students being ready, and we're not talking about physically ready, we're talking about being mentally prepared and what is their level of expertise when it comes to handling things like weapons, etc. Arguably, this could be an accident waiting to happen. Unfortunately, when he whipped that student round there, the student flagged the instructor. He could very easily have had his finger inside the trigger well, pressed the trigger and shot that instructor in the body or in the face. This is something that might look cool, but you've got to be really, really careful when it comes to doing something like this. And you have to ask yourself, is this appropriate? The last thing I want you guys to do is go out and have accidents and students getting hurt and, God forbid, instructors getting hurt. I'm not going to say any more on this one. I'll let you draw your own conclusions. So if we go back to where we were, there's true stress and then there's false stress. I would argue this is a good example of a false stressor. If you are being harangued and you're being harassed, even if you're in a firefight like this, you need to be shooting the person that's doing that haranguing as opposed to the enemy, because they're going to be the greatest threat to you. I say that tongue in cheek, but you need to make sure that whatever stress you give your patients, or should I say you give your students, it's real and it works, it's not false, and it's going to be appropriate for the scenarios that they're going to be moving into. So keep it relevant. Do not put stress into your scenarios or your reality-based training too early. Get them to that conscious competence. Remember, they can do it, but they have to think about it first. Avoid too much too soon. Remember I said about overload, and be careful not to overwhelm the student and create this negative learning experience. I have seen students on other training I've been witness to literally throw their gear on the ground, say, this is beep. I don't see why we should be doing this because I just don't know. Why am I doing this? I don't understand. Actually, I was there when a student did this. He was part of a special weapons and tactics team. And he had already had a conversation with me earlier on in the day, questioning the need for wearing personal protective equipment because they wore it for training all the time. When in actuality, when we ran them through a training scenario with his PPE on, it didn't fit very well. And it actually increased more stress upon him because he couldn't concentrate on the medical side of things because he was forever trying to fix himself when it came to handling of his weapon system, handling of his body armor, and all the other equipment he was wearing. So be mindful of that. Don't berate when you debrief. You did this wrong. You did that wrong. Why did you do this? Most of the time, those students know what mistakes they made or know or have already identified what they want to do next time. So allow them to recognize that failure and allow them to correct it. So a good way of doing that when you're doing your debrief scenarios, debriefs after the scenarios, is saying, okay, guys, how do you feel about that? First thing people will do is they'll stick their hand up and say, we didn't do this, we didn't do that. I go, hang on a second. Okay, tell me one thing that you think you did well. And they're not expecting that question to be asked. And when they talked to the patient, when they communicated to the patient well, when they recovered the patient to a safe place, those were all good things that they did, but they're just not recognizing them. They're just focusing on the failures. Then when it comes to the thing that they could do really well, rather than saying, now tell me what you did wrong, what you want to do is rephrase it and then ask them, if we were going to run this scenario again, is there anything you might do differently next time? So we're being more analytical. And this is not about tree hugging. This is about talking to people as adults and getting them to think about what they're doing. Remember, I mentioned this SWAT guy who kind of gave up, threw everything on the ground. The reason they made the mistake, or they had the problem, was because of ill-fitting personal protective equipment. So in actuality, it had nothing to do with knowing what to do or being able to do it. It was because he was preoccupied, or they were preoccupied with something else. Fix those issues, adjust the body armor, remove some of the items that actually don't need to be there, make sure that the helmet fits correctly, and they actually find that their performance improves tenfold because they're not preoccupied, and then they can do what they need to do, and they do it correctly. So reality-based training, if you want any references when it comes to doing RBT, then look at Kenneth Murray 2006, Faster Than the Speed of Light. There's also another good article, Christensen 1997, Deadly Force Encounters. And we've got other publications, Driscoll and Quell in 2011, The Instructor Guide to Reality-Based Training. These are really good reference manuals for you as training centers and instructors when it comes to organizing and going through the ADDI process when you're looking to develop your reality-based training. It is an art in itself. Some people do it really well, some people not so well. Use only scenarios that are relevant to your students. And if you don't, remember, you're going to fail to engage them. They need to understand why they're doing it. Then they will do it. If they see it as being something that's beneficial to them and it's relevant to them, then they're going to want to do it even more, and they will interact with that scenario even more. We have playbooks. So we've got a scenario or a session that we want to deliver. We know and understand what equipment we need, so we can have that set up ready. And we know the number of staff that we might need, and we've got a breakdown of how we want that scenario to run. Now, I should be able to give that to any experienced instructor. They've got everything they need in terms of a reference. They don't need to make it up or do it off the cuff. They've got something that they can use, and they are able then to maintain the appropriate standard. This picture here, actually with the canine casualty, we've got a bandage being put on the dog. I would argue that maybe we're not following the necessary standard. We're not muzzling the dog before we address massive hemorrhage. So if any of you have seen that, don't worry, I've seen it already. And we need to put a picture on here that's got a dog with a muzzle. Hey guys, you don't always need to go high tech. We can use those standard Resusciani mannequins that are not 200,000 US dollars. And with a little bit of ingenuity, using some PVA or some decorators caulking, we can create wound shapes, we can paint them. They can actually be glued and fixed onto our training mannequins, and then they can be taken off. And those wound patterns be reset if you want to do another scenario using the same mannequin. You can also clean them up pretty quickly as well. In the bottom picture here, we've got a multiple trauma patient, and these are all moulages that we've created with PVA and caulking. So guys, educators, instructors, teachers, trainers, you need to get yourselves educated. Learn how to be an educator, a teacher, and a trainer. Get yourself experience, and I don't just mean passing a TCCC or TECC course and then teaching it. That doesn't qualify you to teach that program just because you've done the course. You need to get your hands on some real people first in real life scenarios. I advocate that all instructors and all our instructors undertake formal training in adult education. In fact, I'm going through that process to become a fully qualified teacher right now. And that will help you understand how you should be teaching. And really, there is no natural instructor or teacher. Being able to stand up and talk to people, I would argue, is a natural skill in some part, but you need to be able to create confidence, and you want to be able to pass on the right information, and you want to be able to keep it relevant. Make sure you know and understand the needs of your students, especially when it comes to tactical casualty care training. It's no longer only for military or police personnel. We have people that come from the UN, through the security industry, who some of them may not be even ex-military. So they're not coming with those skills, but they want to follow a certain career path. And why shouldn't they? But they need to be given the right training to be able to do that. Sometimes we've had conversations with potential student candidates and said, hey, you know what, maybe this course isn't for you. Maybe you need to go out and get some real life experience first of handling patients before you come to us. There's a lot of people that get in touch with us and say, I want to be a tactical combat casualty care instructor. Great, that's fantastic. What's your background? XYZ, and I work for a civilian company and I have no military experience and I have no first responder or pre-hospital care experience. But I've done a combat lifesaver course and I want you to teach me to be an instructor. I'm going to turn this person down and I'm going to do it as best I possibly can, but I'm going to say to them, I'm sorry, but you just don't seem to fulfill the prerequisite. You're going to need experience. You're going to need tactical training before you come on a tactical instructor's course. I need to be able to keep my training real and I need to be able to keep my training relevant. I expect the same of my instructors. And if they can't relate to previous experience, if they can't relate to those skills, field craft, weapon handling, then they can't teach it to other people. So guys, if you've not got it, go out, get some more experience, continue to treat real patients, and make sure you stay up to date with your current practice. Continue to learn. Like I said, I'm still a student. There's no excuse for me, even if I'm a company owner or a training director, to not still be learning about casualty care. As training centers, we need to be able to get ourselves approved so that we can deliver and award certain levels of certification. Now that requires somebody else in terms of an educating authority coming to you, coming to your center and assessing you. Now, if you're a good center and you're providing a good standard of training and you've got experienced instructors, that should not be an issue for you. You should not be worried about people coming in through your door and assessing you and possibly being critical and giving you negative feedback. If you don't get negative feedback as a training center, then you're not going to know how you can improve and provide a better service for your clients. So get yourselves assessed, get certified by recognized educational institutions, and this could take time. For us, when we went through the process as a training center in the Czech Republic, it took nearly 2 years by the time we were able to get an affiliate faculty to come to us, witness our training, and then allow us to become authorized as a training center. Get assessed by outside assessors. If anything, it's going to benchmark you so you know where you are, and again, so that you can develop yourself and make yourself a better institution. Students, and this is a message for all you students out there who might be watching this, all of you out there who might wish to become tactical medical instructors, the cheapest is not always the best. Make sure you shop around and don't be afraid to ask any questions of those training centers. If you want to send us an email, if I can't do it, most likely I can pass you on to somebody, give you a contact of somebody that may be able to help you. Training centers should not be afraid of asking those questions, and training centers should not be afraid of turning business down. It's not about the money, remember, guys, it's about the patients in our care, and that is why we're here. And most certainly that's my motivation and our motivation for delivering the training that we do deliver. Why do we care? Well, here we go. This is an example of one of those patients that's going to be in our care. We're not doing it for ourselves. We're not doing it for our egos because it's cool. We're doing it for the people that are injured during conflict or, God forbid, a terrorist act. And if we fail to teach our students right, then ultimately these are the people that we are failing. So thanks for your time. I hope you've enjoyed this presentation. Some credits are going to come up in a bit, and there'll be an email address for you to be able to contact us, me, on. If you have any questions on the stuff that I've talked about, if you've got any criticisms in the video, maybe how we can make things better or improve upon the learning environment I've tried to create here, then let us know. Most certainly I've learned a few things this afternoon about Zoom and how to operate it. But again, I hope you've enjoyed it, and thanks very much for your time. I'm going to stop this and I'll say cheerio for now.